Welcome back to the class Anatomy of the Facial Beauty. Last week we have overviewed the cephalometric landmarks. This week we will cover the cephalometric planes of the reference in a row of the topic cephalometric analysis. Following the location of the reference points, as known as the landmarks, it is possible to draw reference lines or planes. Linear measurements may be made by connecting two landmarks, and angular measurement may be made by connecting three landmarks. Numerous lines or planes may be used depending on the cephalometric analysis being employed, and each analysis is based around one or more reference planes. Before going to look over the various planes of cephalometry, there is an issue to be remembered. Each cephalometric analysis used in craniofacial evaluation requires one or more reference lines or planes, which are formed by joining some reference landmarks or points, other than the true horizontal and true vertical lines. Variations in the position of reference landmarks and thereby the orientation of the reference lines will affect the measurements. Therefore, the effectiveness and practicality of each analysis depends on whether the selected reference points are in ideal positions and thereby depends significantly on the presenting craniofacial deformity. For example, the sagittal position of the bony chin may be related to the perpendicular line from the Frankfurt horizontal plane through nasion, but this will only be useful if the sagittal position of nasion is correct and the orientation of the Frankfurt plane is ideal. The only reference lines not subject to such a problem are the true horizontal and true vertical planes based on natural head position. Okay, now move on to the hard tissue lateral cephalometric reference planes. Let's see how many kinds of reference planes are used in the clinical diagnosis. First, we are talking about the horizontal reference planes. Sella entrance to nasion, SEN plane. Its definition is a line joining the sella entrance point SE to nasion. The layer horizontal line is known as superior cranial baseline. This line is a line joining endpoint with the apex of the posterior clinoid process, as known as a PCP. It is described by the craniofacial surgeon John Delaire, who is known for developing the Delaire face mask or reverse headgear. Sella nasion, SN or SN plane. This is very famous plane and it is defined by a line joining sella and nasion, approximately indicating the anterior cranial base. The next is optic plane. The supraorbital plane is drawn tangent to the superior contour of the anterior clinoid process and the roof of the orbit. The infraorbital plane is drawn tangent to the lower border of the sella turcica and the plane of the orbit. The orbit plane bisects the angle formed by the supraorbital and infraorbital planes. It is described by the orthodontist Vincenzo as an alternative to Frankfurt horizontal planes. The next is the also very famous plane, the Frankfurt horizontal plane. It can be abbreviated frequently FH plane. It is a horizontal line connecting the cephalometric landmarks Pogonian and Orbital. The next is the constructed Frankfurt horizontal plane. The abbreviation form is the FHC, small c. It is a horizontal line drawn through sella at 7 degrees less than the sella nasion line. It is described by the orthodontist Charles Burston. Maxillary plane, MXP. It is also called palatal plane. It is defined as a line joining posterior nasal spine (PNS) and anterior nasal spine (ANS). The next is the occlusal plane. It can be abbreviated as OP. It is defined as a line on the cephalometric radiograph representing an imaginary plane at the level of the dental occlusion. Three distinct planes may be defined. The first is the maxillary occlusal plane, MXOP. It is a line joining the maxillary first permanent molar cusp tip to the incisor edge of the maxillary central incisors. The second is the mandibular occlusal plane. MNOP is an abbreviation form of this plane and is defined as a line joining the mandibular first permanent molar cusp tip to the incisor edge of the mandibular central incisors. The third and final one is the functional occlusal plane, FOP. It is defined as a line drawn passing through the occlusion of the premolars or deciduous molars and the maxillary and mandibular first permanent molars. The next is the mandibular plane, MNP. It is defined as a line or plane connecting gonian and menton, representing the inferior border of the mandible in the sagittal plane. The mandibular plane may also be drawn as a tangent to the inferior border of the mandible. The next is the vertical reference planes, Nagian perpendicular. It can be abbreviated N perpendicular. A line drawn perpendicular to the Frankfurt horizontal, or ideally the true horizontal plane, from Nagian. It is described by the orthodontist James McNamara Jr. Facial plane. Strictly speaking, it can be said as a skeletal facial plane, a line joining Nagian to Pogonian. Deleo vertical line. The craniofacial balance line described by the deleo is a vertical line dropped from a point slightly posterior to M point along the MPCP horizontal line. Actually, this point is representing the articulation of the frontal process maxilla with the lacrimal bone. In an attractive Caucasian profile, this line is said to pass through the nasopalatine foramen and bony menton, thereby determining the sagittal position of the maxillary and mandibular skeletal bases. A Pogonian line. This line is defined as a line connecting maxillary point A to bony Pogonian. It is described by the orthodontist Robert Ricketts, used in the Downs analysis and popularized by the Raleigh-Williams. Y-axis. This line is defined as a line joining sella and nathian. Facial depth line. It is defined as the line joining Nagian and gonian. Posterior ramus plane. This plane is a tangent to the posterior border of the mandibular ramus. Okay, let's move on to the soft tissue lateral cephalometric reference planes. The first is the E line. It is also called as the aesthetic line or plane of Ricketts. It is described by the orthodontist Robert Ricketts as a line tangent to the chin Pogonian and the nasal tip pronasal. It is used to analyze the prominence of the lips. It is used very frequently. The next is the facial plane. It is the soft tissue facial plane. It can be defined as a line joining soft tissue nasion to soft tissue Pogonian. H-line. It is also called as a harmony line of the holdaway. It is described by the orthodontist Riddle holdaway. The H-line harmony line is drawn from the soft tissue Pogonian tangent to the upper lips. LS. Labial superius. Rees aesthetic line. It is described by the plastic surgeon Thomas D. Rees. This is a line tangent to the nasal tip pronasal and upper lip labial superius, which should pass near the bony Pogonian in an attractive facial profile. The next is the Riddle Plane. It is described by the orthodontist Richard Riddle as a line tangent to the upper lip, lower lip, and soft tissue Pogonian. Its advantage is that it eliminates the nasal prominence from the analysis. S-line, which means the Steiner line. It is described by the orthodontist Cecil Steiner. The S-line is drawn from the midpoint of the S-shaped curve between the subnasal and pronasal to soft tissue Pogonian. It is used to analyze the prominence of the lips. SN soft tissue Pogonian line. Burston line. It is described by the orthodontist Charles Burston. The subnasal to soft tissue Pogonian line may be used to evaluate lip prominence. The advantage of this line is that it eliminates the nasal prominence from the analysis. The next is the 0-degree meridian. It is described by the plastic surgeon Mario Gonzalez Ulloa, and it is a vertical line dropped from the soft tissue nasion, perpendicular to the Frankfurt horizontal plane. The finally introduced plane or line is the Z-line. It is described by the orthodontist Levon Merrifield. The profile line or Z-line is drawn tangent to soft tissue Pogonian and to the most prominent point of either the lower or upper lip, whichever is most prominent. Ideally, the upper lip should fall on the line and the lower lip should be slightly behind. The angle formed by the intersection of this profile line and the Frankfurt horizontal plane, or ideally the true horizontal plane, is referred to as the Z-angle. Okay, let's continue with the posterior anterior cephalometric radiography. Individuals presenting with facial asymmetry require evaluation of the facial skeleton in the frontal view with a posterior anterior cephalometric radiograph. This radiograph is ideally taken with the patient in natural head position. Identification of the mid-sagittal plane permits evaluation of bilateral dentoskeletal asymmetry. This is followed by identification of the bilateral landmarks, which are connected as horizontal line to form a transverse plane. The relative orientation of these planes aids in the evaluation of the vertical skeletal asymmetry. Now we are going to look over the hard tissue posterior anterior cephalometric reference planes based on the hard tissue posterior anterior cephalometric landmarks discussed in the former lecture. First is the vertical reference plane, the mid-sagittal plane. It is a vertical line drawn through crista galli and nasion, parallel to a true vertical line. It should pass through ANS between the central incisal teeth and through menton. From now on, the horizontal reference planes will be introduced. First is the superior transorbital plane. It is a line connecting the most superior point on the contour of the left and right superior orbital outline. The next is the interlateral orbital plane. This line is a line connecting the left and right lateral orbital LO points. Intermediate orbital plane. It is defined as a line connecting the left and right medial orbital MO points. Transverse plane. It is a line connecting the most superior point on the outline of the left and right petrous part of the temporal bone. Interzygomatic plane. It is a line connecting left and right zygoon JY points. The next is the inferior transorbital plane. It is defined as a line connecting the most inferior point on the contour of the left and right inferior orbital outlines. The next is the intermaxillary plane. It is a line connecting the left and right maxillary MX points. The next is the occlusal plane. The transverse occlusal plane may be evaluated by a line connecting the left and right maxillary and mandibular buccal molar cusps. There may be separate maxillary and mandibular planes in the presence of the lateral open bites. Regarding with this line, there is a canine line. Canine line is a separate maxillary and mandibular canine line may be drawn connecting the left and right canine cusp tips. Incisor line. Incisor line is a separate maxillary and mandibular incisor line may be drawn tangent to the incisor edges. Intergonial plane or bigonial plane. It is a line connecting the left and right bony gonian points at the mandibular angles. Intermental foramen plane. It is a line connecting the center of the left and right mental foramina. This landmark is easier to identify on three-dimensional reconstructions. The final line or plane I will introduce to you is the inferior chin plane. It is a line drawn on the inferior border of the chin through menton with maximum bone contact. The next topic we will discuss is the geometric principles in cephalometric analysis. There is no royal law to geometry. This was the response of the Euclid to Ptolemy I, the king of Egypt, at the time of the 300 before Christ, and who was the Greek mathematician at that time, when asked if there was an easier way to solve the theorems. Cephalometric analysis essentially applied geometry. That is to say, the geometry applied to the understanding the structural relationships of the craniofacial complex. Cephalometric analysis has an important place in the diagnosis, treatment planning, and treatment result analysis of patients with dentofacial and craniofacial deformities. There is a vast array of cephalometric analyses. Each analysis has some merit, yet will not be applicable in all cases. Therefore, no claim can be made for the universal application of any specific analysis. With training, clinicians will become familiar with certain aspects of each analysis, which are useful in the diagnosis of specific facial types and deformities. In addition, time spent in analyzing patients using different analyses will teach the clinician to see When it comes to cephalometric analysis, a little learning is a dangerous thing. Clinicians must appreciate the geometrical relationships which constitute each aspect of cephalometric analysis, and not fall into the trap of attempting to treat cephalometric norms. Without such a thorough understanding, it is easy to misdiagnose, thereby leading to incorrect treatment planning. The description of the dentofacial deformity. The dentoskeletal structures of the face are like the scaffold over which the soft tissue drape. The facial skeletal framework is concealed under the facial soft tissue drape. Therefore, in addition to the primary clinical analysis of the facial soft tissue relationship, accurate and detailed evaluation of underlying dentoskeletal pattern requires analysis of the lateral and posterior anterior cephalometry radiographs taken in natural head position. In highly complex cases, such as severe craniofacial asymmetries or craniofacial syndromes, three-dimensional imaging is also required. It must be also emphasized that it is the fundamental underlying relationships of the structural components of the facial skeleton to one another and to the craniofacial complex that need to be established and evaluated with the aid of the clarification afforded in using selected parts of the relevant cephalometric analyses as a diagnostic guides. A thorough knowledge of craniofacial dentoskeletal anatomy is paramount to understanding cephalometric analysis. The facial skeleton is formed of a number of combined morphological and structural components. Although these constituent parts are related to one another and to the overlying soft tissue, they may be depicted as illustrated as distinct for descriptive purposes. Individuals' morphological components may deviate from the norm, yet their combination coupled with variation in the overlying soft tissue thickness and dental-alveolar compensation may result in an acceptable facial aesthetics and normal dental occlusion. On the other hand, individual components may be more or less within normal range, yet the particular combination of components may lead to poor facial aesthetics and dental malocclusion. Therefore, measurements of individual morphological components are of no practical significance when assessed in isolation from the overall craniofacial complex. It is essential to recognize that most individuals will have variations in the size, shape, and relative position of their dentoskeletal structures, and the possible combinations of these morphological components are extremely diverse. Therefore, rather than relying on any simple system of classification, a more effective approach is to describe sequentially and comprehensively the arrangement of the various morphological components in relation to one another and to the craniofacial complex. So, it is very important to understand the geometric principle required to fully appreciate cephalometric analysis, bearing in mind that the clinical evaluation always takes precedence over cephalometric analysis. Ideally, cephalometric analysis will follow, corroborate, and add to the clinical evaluation. Where this does not occur, further evaluation is required to seek the source of the discrepancy. The results of the various dentoskeletal analyses may be integrated to provide a reasoned and coherent representation of the dentofacial pattern of the individual. It is important to examine the dentoskeletal relationships using more than one cephalometric analysis because for structural and geometric reasons, a single measurement of analysis may be misleading. The assessment of the dentoskeletal relationships should be undertaken using analyses and thereby measurements that are based on different reference planes. For example, the use of SNA and SNB angles to assess the sagittal position of the jaw may be misleading because of the variation in the orientation of the SN plane. An independent measurement such as the sagittal position of the jaw in relation to the nasal perpendicular would provide a useful check. When two independent measurements from different analyses reinforce one another, they may be accepted with confidence. But when they do not, the reason for the discrepancy must be sought. At this time, two commonly used clinical terms require definition. The first is skeletal pattern. This term describes the relationship of the maxilla to the mandible in all three planes of space. That means sagittal, vertical, and transverse. It is a primary consideration in clinical diagnosis. It may be referred to as the skeletal pattern or jaw relationships, although the term dental base or skeletal base relationship are also sometimes used. Classification of the skeletal pattern describes the relative position of the underlying skeleton, referred to as the basal bone, of the maxilla to the mandible, excluding the dental-alveolar processes. The second is the dental-alveolar or apical base relationships. The relationship of the maxillary and mandibular dental-alveolar processes, as known as the apical bases, to their respective skeletal bases and to the craniofacial skeleton. Accurate, orderly, and objective description of these dentoskeletal structures and their overlying soft tissue relationships will permit the systematic description of the presenting deformity. Okay, this is the end of today's lecture, and we will be discussing about the skeletal relationships and dental-alveolar relationships in the next time. Stay tuned. Thanks for watching.